hematologic malignancies, the therapeutic opportunities have rapidly advanced over the past 7 or 8 years. These include genomic subtyping of various lymphomas with particular alterations, and this has assisted with subtype and prognosis. And then we've watched with the advent of cellular therapy, particularly the chimeric antigen receptor or CAR T-cell field, which has revolutionized our approach to hematologic malignancies. And after 5 or so years now of CAR T-cell therapy based on clinical trials, specifically in diffuse large B-cell lymphoma, follicular lymphoma, we also have protein-engineered bispecific antibodies that are in some ways treating a similar patient population, but demonstrate the major advantages of prospective clinical trials. So on the one hand, patient access to novel therapies has been enhanced. On the other hand, both of these require specialized centers with expertise and toxicities and patient management. And the short and long-term toxicities, including cytokine release syndrome, as well as some cytopenias, require specialized patient management surrounding multidisciplinary teams and supportive care. Also, there's substantial manufacturing time, and a lot of this was done in the context of clinical trials. And so at the recent Chemotherapy Foundation, a real-world data presentation was made that focuses on what are the groups outside of the registrational clinical trials that are being treated now with the CAR T-cells or bispecifics. And often these turn out to be patient populations not usually enrolled in the prospective randomized trials. And in this real-world data presentation, Black and Hispanic populations, or those in rural and underserved areas where they may not have the socioeconomic resources that others do when we report out the clinical trial that led to the FDA approval, Blacks had experienced an inferior progression-free survival, and Hispanic groups appeared to have slightly worse overall survival. So it's clear that we need to accumulate real-world data, analyze these registries. In the real world, patients may be sicker, may not have been enrolled on the trials, and the ultimate outcomes in every racial or ethnic or socioeconomic group may not always mirror what we saw in the initial prospective trial. And it's important to manage and have interventions, recognizing that health outcomes with these expensive therapies need to be optimized to benefit as many populations as possible. So these are important analyses, kind of post-marketing phase 4 studies and real-world data that enable us to expand these novel therapies that have been so exciting to as many patients as possible in the field of oncology.